We have three more wonderful lectures today. Just a few housekeeping things. So it's a Zoom webinar. Please feel free to use the chat for any participation throughout the lectures or any questions. And we also have the Q&A function enabled as well, and we will be moderating that. So for our first lecture this morning, Dr. Hassan, are you here? And I want to test that you can share your screen.
Okay, I'm going to try to share here. Let's see.
Wonderful, we can see it. Okay. All right. So we do have a co-moderator from Ethiopia, Dr. Demeki. Do you want to introduce yourself briefly? Not sure if the audio is working, but at the end of this, Dr. Demeki is from, she's an assistant professor of cardiology from St. Paul's Millennium Memorial College, and will be helping to co-moderate from Ethiopia. So I'd like to introduce our first speaker, Dr. Lauren Hassan. She is a clinical assistant professor of cardiology at Ohio State University, and she will be talking to us about cardiovascular disease during and after pregnancy. Thank you.
Thank you so much for having me. It's such a pleasure to be able to speak with the group. I'll go ahead and get started here. I don't have any disclosures. A lot of times I begin talking about cardiovascular disease in pregnancy with a review of maternal mortality trends in the United States, but I thought perhaps I'd make it a bit more relevant to this audience by focusing on kind of Ethiopia as an example of what we kind of see overseas. Maternal mortality trends have been improving, at least according to this data that I have here. You can see this MMR here on the left, which is maternal mortality ratio, has been decreasing, which is a good thing. That's maternal deaths per 100,000 live births. And then when you kind of focus in a little bit more on what are the causes of maternal mortality, which we never want to have a young mother pass away as part of childbirth, right? That should not be something that happens, but it certainly does. When you zoom in a little bit more on the causes, you can see that a large proportion of the causes, both in Ethiopia and other African countries, but then also in the United States, are related to heart disease complications, either during pregnancy or in the postpartum period, or even in the year after birth. So here, this is kind of older data from 1990 to 2013. And you can see that this other direct causes, when I dug into that a bit, that does include things like cardiomyopathies. And then some of the more common things are included as well. Maternal hypertensive disorders are in this 10% yellow block here. Looking a little bit more recently, now this is during a time of conflict, I understand. There are some other causes that have kind of risen to the top here, but you still see that there's a lot of these listed causes of maternal mortality that are related to cardiovascular disease, including hypertensive disorders, lots of different cardiac diseases, either before or acutely during pregnancy. So I think that this underscores the importance of learning more about this topic and trying to do more to take better care of these mothers. So today, we're going to talk a little bit about physiologic changes in pregnancy. And then I was going to spend the most time addressing some of the more common concerns that we encounter for women during pregnancy, which would be hypertensive disorders, and then arrhythmias, palpitations. And then we'll touch on at the end a little bit on cardiomyopathies and acute coronary syndromes. So starting with physiologic changes in pregnancy, during pregnancy, the body naturally undergoes a lot of changes to accommodate growth and development of the fetus. And many of you may already be aware of some of these hormone shifts that occur and they prompt changes in hemodynamics as well. This graph kind of depicts some of those hormone changes over the course of pregnancy and then into the postpartum period. So you've got increases in estrogen in the first trimester, which increases things like plasma volume, stroke volume, and heart rate, which altogether really produces a pretty marked increase in cardiac output of about 30 to 50%. And of course, that's needed to supply that extra life in there. And then a decline in systemic vascular resistance, which is produced by prostaglandins, kind of helps balance this out a bit. After delivery, this is a common time when things like cardiomyopathies either surface or complications occur because there's a kind of a sharp decrease in heart rate and stroke volume, but systemic vascular resistance shifts kind of more gradually back to normal. And then you also have kind of an auto transfusion in that period from the uterus. And so lots of volume is going into the system. And so those things can be challenging for somebody with heart disease to adjust to. So how do we really determine who is at risk for having some sort of cardiac event during pregnancy? Well, there are some scoring systems out there. This is an example of one that we sort of have put into a table here called the Modified World Health Organization classification of event risk. And what you're doing with this sort of risk score is basically looking for what group your patient would fall in by reading through the list of different diagnoses, and then the authors of this sort of risk score have determined roughly what their event risk might be if they were to fall in one of these categories. So this can be really helpful if you're trying to counsel somebody prior to pregnancy about what their risk might be, or if someone is already pregnant and you are trying to decide whether they might need to deliver at a center with a little bit more resources. I think having some numbers sometimes is helpful for patients. So just as an example, a lot of patients, and we'll talk about palpitations, will have sort of just some extra beats here, and that really their risk is not elevated a whole lot. But on the other end of the spectrum, a woman with an ejection fraction that's reduced less than 30%, or who has pulmonary arterial hypertension is at the highest risk. And oftentimes they're quoted a possible mortality of like 50%. And so this might be, if you have the opportunity to discuss with the woman prior to pregnancy, you might discourage pregnancy, or at least inform the person of their risks of having an event during pregnancy. So there's a couple of other ones out there. There's another one called the CARPREG score. But this one, I thought I would just give you kind of an example of what's out there to really help us to decide who's at risk, who needs to be followed during pregnancy, who needs to be, tried to deliver at a center with a bit more resources and things like that. So starting with hypertensive disorders of pregnancy, one of the most common things certainly that we see here in the United States, and then that you see over there as well. So hypertensive disorders of pregnancy is kind of a bucket term that includes a lot of different diagnoses. It's a spectrum really of disorders. The unifying diagnostic criterion really is elevated blood pressure greater than 140 systolic or 90 diastolic. That would be occurring on several different occasions, not just on the first visit. If it's pre-existing prior to pregnancy, or you diagnose it before 20 weeks of gestation, we call it chronic hypertension. After that, you would consider it gestational hypertension. And then you would look for things like proteinuria or other severe features like thrombocytopenia or severe range blood pressures to diagnose preeclampsia. You can have preeclampsia without proteinuria if you do have some severe features present, which I think is something that changed in the diagnostic criteria really in maybe the last decade or so. Also in the spectrum, we've got HELP syndrome, which is where you have elevated transaminases, thrombocytopenia, usually right upper quadrant pain. Eclampsia is the most severe of these disorders with seizures. And so preeclampsia essentially is thought to be this kind of a precursor to eclampsia. And so by treating preeclampsia, you're trying to prevent the seizures. Postpartum hypertension is listed on here as well. We certainly encounter that a lot, and it may have to do with somebody perhaps with a predetermined sort of risk for hypertension, who then doesn't tolerate those postpartum volume shifts very well. So how do we manage hypertension during pregnancy? I thought, yeah, let's go back here. Oh, okay. Evaluating hypertension during pregnancy. Sorry, I have an extra slide here. So this is a kind of a basic review of what labs you might obtain or other testing. Of course, it just depends, I think, on what resources you have available to you, what you might choose to order. Basic, LFTs, chemistry, a blood count, of course, protein being one of the important ones, a spot protein just to look for evidence of preeclampsia, and this would be more so later in pregnancy. An EKG and an echo if clinically appropriate and available. I would say I don't necessarily obtain an echo in every patient with high blood pressure during pregnancy, but if they have signs where you're concerned, about developing heart failure or it's a new diagnosis with severe features or something like that, you might be inclined to do so. And so how much you go about managing it. So the first line really would be an oral agent such as labetalol or nifedipine. And those are the agents really with the best safety data in pregnancy. And we always want to try to bring down blood pressures more gradually with our orals. So these are kind of the ones that we most commonly use. Labetalol can sometimes be dosed, as like 3 times a day, which is sometimes challenging, I think, for women. But that is a good agent that we know is safe. I haven't had to use methyl dopa very often, but it is considered like a second line agent because there's pretty good safety data. And then for severe hypertension, typically, of course, in the hospital, you might require an IV agent. And again, you can use labetalol, also hydralazine or nicardipine. You sometimes have to get creative and use other meds when just sort of counsel the patient about the lack of data that there might be for safety for those medications. So, of course, taking care of the mom is really important to the health of the baby as well. Your threshold for initiating or titrating medications is going to be 140 over or 90 for chronic hypertensives. That's people who are coming into pregnancy with a diagnosis of hypertension. We do have data now that shows that those women do really well with more tightly controlled blood pressure. For gestational hypertension, the threshold for initiating medications is still very high. I expect that in the coming years, we'll probably find that those women do just as well with the lower blood pressures as the women with chronic hypertension. But the concern has been that if we get the blood pressure too low, then it may impact perfusion to the fetus. And so traditionally, we've been pretty conservative with treatment there, but I expect that likely that will change. In terms of agents to not use, contraindicated agents in pregnancy would be ACE inhibitors, ARBs, any kind of aldosterone antagonist, atenolol. Not using a whole lot of direct renin inhibitors anymore, but that would be another one. If your patient's on any of these prior to pregnancy, you would want to stop them prior to conception and get them started on another agent. And then during pregnancy, you wouldn't reach for one of these. Aside from just the risks during pregnancy, there are risks in the long term as well for these women who have hypertensive disorders of pregnancy. And so oftentimes the development or diagnosis of one of these is sort of a window into their cardiovascular risk in the future. So in addition to caring well for these women during pregnancy, it helps to try to link them to a long-term primary care or a specialist if available to kind of have a personalized risk assessment for the long term as well. These are some of the long-term risks that I was mentioning associated with hypertensive disorders of pregnancy. Things like stroke, heart failure, heart attacks later in life are increased and tend to occur earlier in these patients as well. We aren't really sure why that's the case. It's not so much that the hypertensive disorder of pregnancy causes damage. It's more so that the women who are at risk of those are probably at risk of heart disease in the long term already. And the hypertensive disorder of pregnancy is kind of a red flag of sorts that raises our awareness so that then we can try to move them down to this lower line here to reduce their risk in the long term of developing disease. So just moving on to palpitations and arrhythmias as our next topic. So So palpitations are really extremely common during pregnancy. It's normal for the heart rate to rise, and some women are particularly sensitive to that. But aside from that, is an increase in catecholamines in the plasma and sympathetic activity. Relaxin, which is one of the hormones that sort of relaxes some of the ligaments in the body, has some chronotropic effects, so speeds up the heart rate a bit. And then there's that intravascular volume expansion, which theoretically could maybe stretch the atria or stretch the inside of the ventricle, and really just makes women at a little bit more risk for any kind of arrhythmia or palpitation during pregnancy. So we like to think of it as the pregnancy as being kind of pro-arrhythmic in a sense. The most common ones that we see when you really get a monitor to assess it, premature beats are by far the most common thing that come up, and most of the time those are pretty benign, particularly in a woman who has a normal echocardiogram. But we do see some other ones as well. Supraventricular tachycardia tends to be diagnosed or recur often in pregnancy if you've already had it in the past. And then some atrial arrhythmias, ventricular arrhythmias and block, those being a little bit less common, but at least here in the United States, we are seeing a little bit more of these atrial arrhythmias just because of the changes in the demographics of some of the women who are pregnant. And then cardiac arrest, unfortunately, we certainly see that. It's not something that comes up on a monitor, for example, but something that might happen with women with other disorders as well, like cardiomyopathies, for example. We will talk briefly about a couple of these. I'm sure you're familiar with premature atrial and ventricular contractions identified on monitors in more than half of women. So as I said, really common in pregnant women who are having palpitations, that this is the cause. And most of the time we can reassure them. And then most of the time you can manage with observation. A lot of times if there are a lot of them, typically of PVCs, for example, if you were to order a monitor and 10%, of the beats are PVCs, then I might, want to order an echocardiogram. Or if this is a new finding that's happened during pregnancy, you might order an echo if you have that resource available to you just to reassure you. If really frequent or bothersome, you can treat with beta blockade. If they're really infrequent and the patient is satisfied with just some reassurance, that might be the best way to go. Often women are concerned about taking medications in pregnancy and are just okay with some reassurance. If you do come across supraventricular tachycardia on the monitor, this is probably the next most common one after the ectopic beats. About 20% of patients who had pre-existing SVT. It does pop up during pregnancy as well, again, because of some of those pro-arrhythmic factors. You would consider management of some of the same things that you would use in your non-pregnant patients. So vagal maneuvers and adenosine in the acute setting. But I typically would manage these patients with the beta blocker to try to prevent the episodes of SVT or reduce the heart rate if they were to go into one. Digoxin is actually also considered reasonable management for these patients if they don't tolerate beta blockade. I use beta blockers more often. Calcium channel blockers can also be used. Really uncommonly, ablation can be considered, but that would be really for refractory episodes that are causing hemodynamic compromise, syncope, things like that that are concerning. Typically, we would defer ablation to the postpartum just to avoid the risk and the radiation. Atrial fibrillation and flutter do come up. With this rhythm, you definitely would want to evaluate for any underlying structural disease, obtain some labs to look for thyroid function, for example, electrolyte imbalances, and then consider anticoagulation. And that's really challenging because the scoring that we use to look for risk of stroke in patients with atrial fibrillation, at least in the US, is traditionally that CHADS-2-VASc score, but that's not been validated in pregnancy. So we do tend to use that as kind of a rule of thumb, but it's not the sort of the end of the story, I think. A lot of times we counsel patients about the risks of bleeding, for example, or early, delivery if you're on a blood thinner, for example, before we would initiate a blood thinner. But that is something to certainly have the conversation with the patient about. In terms of controlling the rate or the rhythm, beta blockade, again, digoxin would be considered safe as well. Or calcium channel blockers. Cardioversion should be given if needed promptly to avoid any kind of hemodynamic compromise or poor perfusion to the fetus. There are some antiarrhythmics that are be considered safe as well. Flecainide is one that we do use, and sotalol. Typically, I use those kind of in consultation with an expert colleague, but that might be something that you use to try to keep the patient from having to need hospital care. Ventricular tachycardia, really less common, more often comes up in patients with other structural heart disease. Risk assessment definitely is necessary to determine why are they having this. That's not something we would expect to see in pregnancy. So an echo, perhaps even an evaluation for any kind of coronary disease would be helpful as well. Of course, prompt cardioversion or synchronized cardioversion is important. Hemodynamically stable patients can be treated with IV medication. So lidocaine would be first line. We don't use amiodarone in pregnancy, so lidocaine is kind of your go-to there. Procainamide could be a second line for you. Ablation, again, we try to avoid that. There's a lot of radiation with VT ablation, so we try not to do that unless it's really needed. And if the VT is polymorphic, giving magnesium, as is emphasized down here, as you know, is very helpful. This is just a summary of commonly used medications for arrhythmia. This is a graphic that I borrowed from one of our JACC papers. It kind of outlines for you which things are considered safe. So the green is safe to use. The yellow are things that we use really commonly because there's pretty good data for the most part. Orange are things that really use only with caution or not at all. And then red is do not use. So even some of these things that are in the orange we've used on occasion, like diltiazem, but it would only be, if other agents were not available or the patient did not tolerate them. I have used all of these, really a lot of these things here in the yellow with a lot of comfort. So there's labetalol, metoprolol that we've talked about. These agents, carvedilol and atropine, just don't really have safety data, but there are certainly things that could be used if other things were not available. So moving on just a little bit to talk about cardiomyopathies. This is certainly an area where patients are a bit higher risk for events during pregnancy. And at least here in our institution, typically these women are managed with one of our cardio obstetrics providers, which I'll talk a little bit about our program at the end if we have time. But I think the biggest takeaway that I would want for you to be aware of is that cardiomyopathies are one of our higher risk conditions for complications during pregnancy. So if you were to go back to that WHO risk score that I mentioned earlier on those patients, even if their ejection fraction is kind of in the normal or low normal range, are still at increased risk of events or decrease in their function during pregnancy. So any cardiomyopathy, of course, can present or occur with pregnancy, or the patient may have already had the cardiomyopathy and then became pregnant. But this graphic kind of just shows you the distribution of what we would consider to be the most common. Dilated and peripartum cardiomyopathies have pretty similar morphology, physiology, and those are the most common ones. Hypertrophic is very different physiology from those two, but is also seen pretty commonly. And then on the less common side, but ones that would also be worth thinking about in a differential diagnosis would be a restrictive cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, left ventricular non-compaction spectrum disorder, or Takotsubo's, which is like a stress-mediated cardiomyopathy. Don't tend to see that one as much during pregnancy, but any of these are certainly possible. We also have patients that, for example, have developed myocarditis during pregnancy. That was certainly one that came up during the pandemic, and we certainly are still seeing some of that as well. I want to take a minute to talk a little bit more about peripartum cardiomyopathy in particular. So the definition of peripartum cardiomyopathy is really heart failure, which is secondary to systolic dysfunction, with the diagnostic criterion of having the ejection fraction below 45%. Typically occurs kind of towards the end of pregnancy or in the months following, like 3, 4, 5 months postpartum. It is a diagnosis of exclusion, and oftentimes during pregnancy, we don't really know for sure, is this peripartum or did the patient already have a cardiomyopathy that was not known because they didn't have an echo before or what have you. So really, peripartum is sometimes a working diagnosis until we really have a chance to do a little bit more evaluation in the postpartum period. The incidence is pretty, with a pretty wide range, goes from 1 to 100 to 1 in 20,000, depending on what data you look at and where the data is coming from. It is more common in African women. So you do see some of those higher incidences in Africa, some of the data that comes from Africa. Risk factors, multiparity, so women who've had a number of different children, African ethnicity, as I mentioned, malnutrition, extremes of age, so advanced maternal age being greater than 35, or we do unfortunately see it in some teen pregnancies as well. Preeclampsia is known to be a risk factor for it, as well as other just traditional cardiovascular risk factors like your hypertension and hyperlipidemia and diabetes and things like that that occurred before pregnancy. How to evaluate and manage, and this is sort of an entire specialty kind of, distilled down to one slide for you here, because it takes a lot of sort of coordination to care for these women. Prior to conception, if the woman is, comes to you beforehand and you're able to provide some counseling, a baseline echocardiogram, if they haven't had a recent one, is a good idea. Some colleagues use stress echocardiograms to make sure that their body can respond well to stress. So thinking about pregnancy as kind of a stress test, if you sort of simulate that in advance of pregnancy, that might help you a little bit to think about their reserve. And then, of course, stopping any contraindicated medications. And then as part of that sort of risk assessment, which is hopefully pre-pregnancy, but could also be while the patient is already pregnant, you're going to utilize that risk scoring that I mentioned and any other knowledge that you might have about the patient to try to have an honest discussion of risk with the patient, shared decision-making about whether pregnancy should be prevented or in some cases terminated if the risk is very high, and then engaging any experts that might be available to you. Most of our patients here follow with not just a cardiologist, but a specialty cardiologist who sees pregnant women, but also high-risk obstetricians, maternal fetal medicine, and so forth. During pregnancy, we typically will follow these patients pretty frequently. So for somebody who is fairly stable, I would still see them once a trimester most often with an echo at each visit to make sure that they're not having a decline in their ejection fraction, and making sure that I'm able to examine them to get a sense for their volume status. I typically will utilize biomarkers as well. So I'll oftentimes get a baseline troponin or BNP. So if that's something available to you, you might consider doing that before pregnancy and then trending it. And then avoiding any kind of hypotension or overdiuresis, of course, is important because we don't want to reduce the perfusion to the fetus. Continue any medications that are safe, and really, if you know that the medication is safe or if the risk is outweighing or if the benefit is outweighing the risk, really just trying to reassure mom that it is safe and encourage to continue to take those medications. And then if you can, trying to plan delivery so that volume status is optimized is helpful. Typically, when it comes to delivery itself, the delivery mode is usually up to the OB. We don't typically recommend one delivery mode versus another unless the patient is decompensated. That might kind of impact our decision making on arrival if we didn't have a chance to kind of optimize their volume status beforehand. And then monitoring their volume kind of in the first 72 hours after delivery. As I mentioned, they do get that kind of auto transfusion from the uterus, a lot of volume that kind of goes from the tissues back into the blood vessels and can cause that volume overload state. We typically really see that. If you have like a advanced monitoring in the patient, some of our sicker patients might have a central line through the process, then you really can see that in real time with the central venous pressure rising over the course of a couple days after delivery. Early follow-up is important. Most of the time we'll get an echo after delivery, thinking about blood thinners and folks with a really low ejection fraction because of that hypercoagulability of pregnancy in the postpartum period. In a ventricle that isn't moving very well, they might be at risk for LV thrombus. There isn't data to specifically support recommending that. It's just something that we think about. And then, of course, thinking about the next pregnancy. So discussing contraception, making sure that you're doing the shared decision-making with the patient, and again, counseling them about risks of future pregnancies. Just to summarize, just some of the medications, a lot of these are duplicated from the earlier slides where we talked about things that are safe, not safe. Of course, we're going to want to stop ACE inhibitors, ARNIs, ARBs before pregnancy. After pregnancy, so in the postpartum period, if you have a peripartum cardiomyopathy patient, we really feel pretty comfortable with captopril and enalapril, enzapril. So those are usually the ones that I'll start in that postpartum period if the patient is breastfeeding. Beta blockers are typically okay during pregnancy. There was initially some concern about intrauterine growth restriction, but the risk of that is really pretty low, especially if the patient is on a very low dose, and no concerns really during breastfeeding with that. Diuretics can certainly be used throughout. Of course, during pregnancy, you're a little bit concerned about reducing perfusion to the fetus, but we want to take care of mom. If mom's decompensated, she needs diuretics. And then during breastfeeding, it's still fine to use them, but just bear in mind that you can suppress lactation if you're drying the patient out too much. And then again, MRAs, this is your spironolactone, SGLT2 inhibitors, can't use those during pregnancy. In the postpartum period, you can actually use spironolactone even if they're breastfeeding, but can't use SGLT2 until they're finished. Just talking a little bit about acute coronary syndromes here as we get towards the end. So pregnancy actually increases the risk of MI by 2 to 3-fold if you were to compare women of the same age who are not pregnant. And we think this is related to kind of a mix of hemodynamic changes, hypercoagulability, endothelial function, things like that, changes related to hormones mostly. So if you look here, this is a graphic that kind of depicts some of the most common causes. And these are things that, of course, can occur in anybody. I think differences in your differential diagnosis during pregnancy, SCAD, which is spontaneous coronary artery dissection, causes about 30 to 40% of myocardial infarctions during pregnancy. So certainly something to consider in your pregnant or postpartum patients with chest pain. And what that is essentially a tear. We'll talk a little bit more about that on the next slide, in the artery itself. Coronary disease, still something that comes up a lot, especially as women are getting pregnant at older ages. That's, of course, plaque rupture causing a myocardial infarction, and that's probably about another third, we think, of the MIs. The last third, probably these myocardial infarctions without any obstructive disease, which the abbreviation we use is MINOCA. And that could be coronary vasospasm, and that is something that does occur because of some of the hormone shifts. Embolism, microvascular dysfunction, we sometimes see, less likely to cause a very large troponin elevation, but it can cause it. Always in your differential diagnosis, thinking about things that can cause an elevated troponin, chest discomfort, shortness of breath, but are not necessarily an MI. Things on this list here, making sure that we bear those in mind as well. Angiography, importantly, should not be deferred in an acute coronary syndrome just because of worrying about the radiation. We should proceed with that just as we would in other patients, of course, with caution, but just treating mom is just as important as thinking about exposures to the baby. So this is just a closer look at SCAD, spontaneous coronary artery dissection, which is a diagnosis that's more common in women, can occur at any age, but more common before the age of 50. And then there is a kind of a increase in these episodes in pregnant patients that are pregnant or in that first trimester, the fourth trimester postpartum. Oftentimes it occurs with underlying disease states, such as like a fibromuscular dysplasia, which is essentially an arterial disorder that results in some changes in the arterial beds across the body. Generally, if differences in management between a patient with SCAD versus a patient with plaque rupture and MI is that we don't often stent patients with spontaneous dissections unless they're hemodynamically unstable. Whereas with a patient who has traditional plaque rupture MI, those patients are going to need stented. And then, of course, you have to think about antiplatelet agents such as aspirin and Plavix in the postpartum phase. Sometimes we have to stop those things briefly during delivery. Sometimes we can use IV agents to bridge patients, but that certainly presents some challenges as well. So key points overall, just to kind of sum things up for today, things I would want you to take home from the presentation. Hypertensive disorders of pregnancy are common and they carry both short and long-term fetal and maternal risks. The prognosis and management of arrhythmias is very different depending on the presence and absence of structural heart disease, which you can look for with an echo. Cardiomyopathies carry increased risk of maternal and fetal adverse outcomes. And that SCAD is the most common cause of MI during pregnancy, but of course there are other causes as well. So we don't want to assume that all MIs are due to SCAD in pregnancy. So just wrapping up a bit here, I just wanted to just mention kind of the way that we often manage these pregnant patients here at Ohio State and at other academic centers here in the United States. We do have multidisciplinary teams called cardio-obstetric teams, which typically will include, of course, the patient and their family, but cardiology, maternal fetal medicine, cardio-obstetrics experts, which is a cardiologist who is trained specifically in obstetric care. We have pharmacists who are specializing in this area, anesthesiologists who are accustomed to taking care of not just pregnant women during deliveries, but also women with heart disease and the hemodynamics that go along with that. And then, of course, primary care, nursing, social work, other specialties being included, as well as the patient's general obstetrician. We also have at Ohio State and a lot of other centers across the country a postpartum clinics, which is something that you could consider for patients who've had hypertensive disorders of pregnancy to help them to sort of transition back to the postpartum state in terms of adjusting medications and then providing some of the risk assessment and risk prediction for the future. As I mentioned, these patients are at long-term risk of heart disease. So we want to make sure that we don't just take care of them during pregnancy, but also in the long term as well. So sometimes that can be helpful. The most important thing, of course, is to link them with the primary care provider who can care for them in the long term as well. If you're interested in reading further, there's a really nice JAC, which is our Journal of American College of Cardiology focus seminar. The journal puts out these every once in a while, and it's basically a series of articles with a similar topic. And so this is a 5-part series that kind of talks about in more detail some of these different areas. I didn't talk a lot about congenital disease today, but that would be another one that is worth thinking, more in detail about. And this is a great article to kind of get your feet wet with that. Also, we didn't talk a ton about contraception, just mentioning that it's really important to address that, but thinking about kind of reproductive planning, that's a great thing to kind of focus on today. But today is just sort of a crash course overview. So I definitely encourage you to learn more. So I think that's just about it. And I'm happy to address any questions that anybody might have. And I'll see if I can look at the chat here. I don't see any questions in the chat, but if anyone has any.
Thank you, Dr. Hassan. There are actually a few questions in the chat and the Q&A as well. But first of all, thank you so much for that very comprehensive talk. I know that was a lot of information, but I think you did a really nice job presenting it in an organized fashion that was easy to follow. And I know there's a lot of information to cover in a short amount of time. So really appreciate you going through all of that with us. I know I learned a lot. I'd like to invite Dr. Bistrat. Are you available to unmute?
Hello, everyone. Thank you, Doctor. It was a very nice presentation, and it was very interesting. It was well summarized, and I want to say thank you. It's very interesting topic, and I did my thesis on pregnancy and cardiovascular disease, focusing on the outcome. But I didn't see rheumatic heart disease as one of the heart diseases during the pregnancy. Usually that's more common in our setup. And on my study, the prevalence for rheumatic heart disease was 56%. So it's usually common. Rheumatic heart disease.
Oh, rheumatic heart disease, like valvular heart disease and so forth?
Yes.
Yeah,
So
certainly.
maybe it could be due to, I did the study on tertiary care center, tertiary hospital. Maybe that could be the reason, because those patients will be referred for us. But it's also prevalent in the community. So that's something to consider. That's what I wanted to add, because we're talking about pregnancy and cardiovascular disease in Ethiopia. So yes, currently hypertension is becoming prevalent during pregnancy and also in the general population. So from now on, of course, hypertensive disorders will be more prevalent. Maybe in our next study, maybe that could be the case. But so far, even my references during the thesis showed rheumatic arthritis so far is more prevalent in our setup. But yes, you are right. I have seen the publication. So I got the message. I have to publish my study. So maybe if I had published it, that would be something for you to refer. But thank you. It was a very nice presentation. And we have so many participants here. And if anyone has a question or comment, you are more than welcome.
Looks like there's a few here. See if we can address one. Let's see. So just starting with some of the chat, there was a question about how long to continue remodeling in patients who have peripartum cardiomyopathy. It's a good question. We don't have good data to provide a protocol, but generally the process, the thought process is to continue it for at least a year once the EF is stable. And then if the patient really wants to come off the medications or needs to, then you can gradually discontinue with echo monitoring. But if no contraindication, then it's not unreasonable to just continue them, similar to other cardiomyopathies as well. And then here, let's see. Somebody asked about bromocriptine. It's a good question. So if the patient would like to breastfeed, we cannot use bromocriptine, so it's contraindicated. So a lot of times that is a reason to not use it. There is some data with bromocriptine, but it is not robust. And there's another large trial that's coming out from the US that probably in the next few years, kind of more randomized trials. So with the data that's out there already there's some prospective data, but it's not very robust. So we don't use bromocriptine very routinely here in our population. Another comment here about the rheumatic heart disease. Sorry about that. It's just really hard to fit everything into a talk. So I wanted to make sure that I address the things that are easiest, I think, for an internist to manage. Most of our valvular disease patients are managed by our cardiology and cardiobstetrics team. I think, just briefly kind of mentioning how we would go about that, it would be sort of similar to managing the cardiomyopathy, in that volume status is really important to assess, and that postpartum period is really important time where they might decompensate. And how you manage the patient is really specific to the specific valvular lesion that they have. So in that modified WHO criteria that I put on this slide early on, some of those obstructive valvular lesions, like the left-sided obstructive lesions, like aortic stenosis or mitral stenosis, if those are severe, really they should be intervened upon before pregnancy, or pregnancy should be discouraged, because those are some of the highest risk lesions. So it becomes challenging. And a lot of times those patients at our center are delivered in the hospital, in actually our heart hospital, and they have hemodynamic invasive monitoring. So we actually put in like an arterial line and a central line to monitor those volume shifts throughout, and to help with anesthesia so that it's safe to give. Let's see, future pregnancy contraindicated after resolution of peripartum cardiomyopathy. That's sort of a hot issue. So it is definitely high risk, and I think that's the biggest takeaway. Even if their EF has recovered to normal, there is still a risk that it would decline again with the subsequent pregnancy. So we try not to use the word contraindicated just because we want to use shared decision making, but I typically do recommend against it in my patients, or at least counsel them that the risks are very high with peripartum. If they didn't have recovery of their EF, that would be probably the strongest reason to recommend against it. There's a couple other questions. I don't know how much time I have in the question and answer box.
Probably another 5 minutes or so. Yeah.
Okay. One question is about with pregnant women with atrial fib, with no valvular heart disease, if you can't use CHA2DS2-VASc, then what can you use? So there really isn't a scoring system. And this is a problem really in general with, with pregnancy and treating women, is that we just don't have a lot of data because, people are hesitant to study women during pregnancy because of the risks. So I would say in the experience that I have had, I still kind of do calculate the CHA2DS2-VASc score and I use that as a reference, but just bearing in mind that it's not the be all end all because it has been validated in pregnancy. So if you have a pregnant patient who has diabetes, who has hypertension, they're probably going to be at increased risk and you might counsel them to go ahead and use it, but then it has to be stopped, kind of in the before delivery because you don't want them to hemorrhage with delivery. So it does present some complications. In terms of what anticoagulation you can use, you try to avoid warfarin in the first trimester, but it can be safe in the later trimesters at lower doses. Lovenox is another option that we often use for patients. There's no data that really supports using the DOACs, the newer anticoagulants. Let's see. Somebody asked about, is the lidocaine that we use for cardioversion the same for local anesthesia? I think it's just the way that it's formulated. So giving it with injection under the skin is different than giving it like in the vessels. And then let's see, somebody else asked about future pregnancy. So hopefully we answered that one. The preferred drug for maintenance therapy for SVT. Tartrate or succinate would be fine. Sometimes when I'm first initiating it, I would use tartrate just to make sure the mom is tolerating it okay. But I certainly have used succinate as well, just because sometimes it's easier to do the once daily dosing. But either or, I don't know that there's really data to support using one or the other in terms of risks. Okay. Any other ones? It looks like most things have been answered, I think, but happy to answer any others if they've come up.
Thank you, Doctor. I think you covered almost all of the questions. And I really want to say thank you and appreciate your effort. You tried to focus on pregnancy, cardiovascular disease, and you try to focus on prevalence in Ethiopia, especially for those disorders in Ethiopia. So I think there is one question in particular for liver patients with severe MS, because that's what we encounter here, and that's the most challenging cases we have. And to comment on that, I think the best thing we can do if they are already in labor is to control the heart rate and manage the congestion. That's the best thing we can do if they're already in labor. But the thing I wanted to mention was, if they found those patients in the first trimester, they can send those patients to our center, St. Paul's or Blackline. So if there is a possibility, we can do valvulotomy. So this is a message I wanted to send. If the question is if they are already in labor, if they are already in labor, the best thing we can do is manage the congestion as much as possible and manage the heart rate as much as possible, and to make the labor or the delivery in the setup where they can have intubation if there is a need, because most of our patients after the delivery, usually they need ventilator support because of the flash pulmonary edema. That's what we experienced so far. So this is what we can do if they're already in labor. But if we find them the first trimester, if there is a chance, we can do valvulotomy during the mid and late second trimester, 25 plus or minus 3 weeks. In those times, we can do valvulotomy, and we are doing valvulotomy for these patients as soon as we find them. The problem is either we find them very late, like third trimester labor. At that point, there is nothing we can do unless just controlling those things I mentioned earlier. That's the message I wanted to give. And thank you, everyone. If there is anything you want to add, the floor is yours.
Well,
Do you have
thank you so
anything to
much.
add?
I do want to. Oh, Oh, Dr. Hassan, anything to add to that?
No.
All right. Well, thank you so much. I do want to draw the attention to the participants to the chat. There is a link to the evaluation for Dr. Hassan's talk. You take a moment to fill that out. Thank you so much, Dr. Hassan.
Thank you. You all have a good day. Thank you very much for having me.
Thank you. Okay. All right. Well, moving along. Hi, Dr. Maturu. Let me make sure you can share your screen. Okay, I think we see your screen. There we go. We see your slides, or your title slide. Wonderful. Okay, so we will be moving along now from cardiology to neurology. I would like to introduce our next speaker, Dr. Sarita Maturu. She is a clinical associate professor of neurology and working in the epilepsy division. She's also served as a medical director for some of the epilepsy clinics, I believe. And we do have a co-moderator as well from Ethiopia who will be helping provide some of that perspective, Dr. Michael Tesfaye, who is an assistant professor of neurology at Addis Ababa University. So with that, Dr. Maturu, I will give the floor to you. Thank you.
All right, thank you so much. Let's switch my view real quick. So just to confirm, you can just see the one slide, right? The intro slide?
Yes, we just see the slide, yeah.
Okay, perfect. Well, thank you so much, Dr. Clark, for the introduction. As mentioned, my name is Sarita Maturu. I'm Associate Professor of Neurology in the Epilepsy Division. And today I'll be discussing seizures and epilepsy. I only have one disclosure. I'm on the board of My Epilepsy Story, which is a nonprofit organization for women with epilepsy. Today, I hope to cover these few discussion points. So I'd like to start with defining seizures and epilepsy. I'd like to talk about diagnostic testing after a first-time seizure or after the diagnosis of epilepsy. We'll then discuss the use of anti-seizure medications and the efficacy of those medications. We'll briefly talk about intractable epilepsy, what that means, and some therapeutic modalities. We'll touch base about seizure rescue and action plan. We'll briefly talk about treating special populations, and then we'll end with defining status epilepticus and discussing treatment options. But before we start on those discussion points, I would like to just talk about the why. So why is it important to discuss seizures and to discuss more specifically epilepsy? And I think these following points really tell a story of why epilepsy is so important. So 50 million people worldwide will have epilepsy, and this is the most common neurological disease globally. 80% of people with epilepsy live in low and middle income countries. The risk of premature death in those diagnosed with epilepsy is 3 times higher than the general population. 75% of people living in a low-income country do not get the correct diagnosis and treatment, and many people are faced with stigma and discrimination when diagnosed with epilepsy. So because of all these points, it's so important that we are discussing signs and symptoms with our patients and getting them the right diagnosis. Because the positive part of all of this is that 70% of patients with epilepsy can actually be seizure-free if they're given the right diagnosis and the right treatment plan with the right anti-seizure medication. And so we'll start with our first discussion point now, which is defining seizures and epilepsy. So the definition of seizures actually was derived from the Greek meaning to take hold. Its earliest description is actually from Mesopotamia, and it was described as the falling disease, where people's necks turned, their extremities tensed up, their eyes were open, frothing at the mouth. So very much described a generalized tonic-clonic seizure. However, this kind of turned in a way in the Middle Ages, as it was felt to be more of a demonic origin at this point. And so people used to call this falling evil, under the influence of a demon, or even call them lunatics. In the 1700s and 1800s, fortunately, this kind of fell to the wayside, and people again started to describe it as convulsions or passing mental confusion without any definite physical symptoms. And in the 19th and 20th century, that's when we finally got the introduction of the EEG, and the terminology of major clinical syndromes actually evolved. So by 2005, the definition was described as a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity of the brain. And that's kind of the definition that we use very frequently today. The most modern definition was specifically of a focal seizure was described by Bancode and Tallerod. And essentially it proposes this model, which is an accurate model. So basically patients have an interictal phase, meaning between their seizures, and then they have a beginning of a seizure, which could be a lot of times maybe their aura or their warning sign. They then have an excessive amount of discharges and rhythmic activity, or increased electrical activity, and then there's an end to the seizure, and then they have the postictal phase. Now, during this ictal part, or the seizure part, patients can have many clinical syndromes that are associated with it, and seizures tend to follow a certain network, meaning they typically go from point A to point B to point C. And during this time, many structures can be involved. And so one example would be maybe a seizure starts in the mesial temporal region, we'll just say the amygdala, and that's going to cause an aura of fear. And then as this starts to spread more into the lateral neocortex of the temporal lobe, this produces automatisms, or lip smacking and repetitive movements of the hands and mouth. And then as it evolves and affects the whole brain, then that can cause a generalized tonic-clonic seizure. So many structures are involved at that point, and each point along the way can develop into a different clinical syndrome or a different semiological feature. And so that's defining seizures. Now, when we define epilepsy, we take into account essentially the number of seizures or the probability of having further seizures in the future. So defining epilepsy is termed essentially by the International League Against Epilepsy. And so we've developed 3 definitions for it. The first definition is just having 2 unprovoked seizures occurring greater than 24 hours apart. And so there's 2 key parts to that. The first one is unprovoked. So these 2 seizures cannot be in the setting of hypoglycemia, or anything else that can provoke a seizure. And they have to be more than 24 hours apart. If they're within the 24 hours, it's considered a one-time event, and that's kind of significant, and you'll realize as we go along. The second way to get the definition or to get the diagnosis of epilepsy is to have 1 unprovoked seizure, but a probability that further seizures might occur and to a percentage of 60% over the next 10 years. And how we predict that is through the studies or the workups that we get when someone has a first-time seizure. So that would be abnormalities on the MRI, if patients maybe had a stroke or a tumor or any epileptogenic lesion. So that would be like mesial temporal sclerosis or cortical dysplasia. The second way would be if there is an abnormality on an EEG, and we would call those interictal epileptiform discharges or sharp waves. And I'll show you an example of that in a little bit of what we see on the EEG. And then the third way is if potentially this 1 unprovoked seizure was actually a nocturnal seizure. So if someone comes in and says, I had it in the middle of the night or while I was sleeping, essentially, we feel that the risk of reoccurrence is around, say, 60%. And the reason of why this is because previous seizures might have went undetected. If they're happening in the night, someone lives alone, they probably didn't realize if they were having seizures prior to that. And the third way to get the diagnosis of epilepsy would be to have an epilepsy clinical syndrome. So an example of a clinical syndrome would be childhood absence epilepsy, where patients have staring seizures or seizures where they have behavioral arrest, they're not responsive, along with EEG changes that show generalized epileptiform discharges, or more commonly 3 Hertz spike and wave discharges, which we'll see in a little bit as well. And so why did we come up with this terminology? It's all about percentages. So if you have one unprovoked seizure and you have no abnormalities on the MRI or the EEG, and it was not a nocturnal seizure, then the risk of reoccurrence is 30% to have your second seizure in your lifetime. So at this point, we typically say we don't need to start an anti-seizure medication. And I say typically because every patient is truly different, and you might hear a little bit more about their story, or there might be some other things in their story that you really feel like an anti-seizure medication is indicated. But for the most part, we do not start anti-seizure medications on patients that just have had a first-time seizure and they have no abnormalities on their MRI or EEG, and it wasn't a nocturnal seizure. But if you have one unprovoked seizure and you have abnormalities on your MRI or EEG, or it was a nocturnal seizure, the odds of you having a second seizure in your lifetime go up to 60%, as mentioned. So it's quite high, the jump from just having one unprovoked seizure to one unprovoked seizure with changes on an MRI or EEG. And so at this point, you get the diagnosis of epilepsy, and it's really important that you get started on an anti-seizure medication. Now, if you have 2 unprovoked seizures in your lifetime, the risk of reoccurrence in the next 10 years of a seizure is 70%. So it's even higher. And so at this point, we also start anti-seizure medications. And so sometimes a question that comes up is, why don't we just start an anti-seizure medication after the first seizure, even if the percentage is lower? 30% isn't 0%, so why wouldn't we just start an anti-seizure medication then? And anti-seizure medications have shown that they can decrease the risk of having another breakthrough seizure by half. So if it used to be 30%, it might be closer to 15%. But on the flip side of that, starting an anti-seizure medication is not benign, in the sense that starting an anti-seizure medication can lead to a lot of side effects. And so those side effects you have to really take into account, because that's a medication that they're taking every day. Do they want those side effects every day? And then starting an anti-seizure medication after the first seizure really doesn't improve the overall prognosis of epilepsy. Meaning, if you were going to go on to have intractable epilepsy or difficult to treat epilepsy, that would happen regardless of what you did with that first seizure or not. Starting an anti-seizure medication after the first seizure doesn't reduce morbidity and mortality as well. So as I said, patients with epilepsy have a 3 times more risk of death than the average patient. And this does not decrease by just starting an anti-seizure medication after the first seizure. And then finally, in survey studies, starting an anti-seizure medication after the first seizure has really not shown to improve quality of life. So in general, early intervention with the anti-seizure medication doesn't really outweigh a lot of these negative things that could potentially happen. And so what I like to say with every patient that I first meet and I diagnose with epilepsy is that epilepsy is a journey. Every journey is going to be different, which means that we're going to probably try different medications than maybe they've heard of, or maybe that they thought would be indicated for them, because every person's story is truly, truly different, and we have to tailor that treatment plan for each individual patient. Now, I briefly wanted to talk about seizure classification. We use seizure classification essentially to characterize the seizure semiology for each patient. This helps us localize seizures and lateralize seizures more. And when we are able to localize and lateralize, we can give patients better treatment plans, not just of anti-seizure medications, but if they become intractable, meaning difficult to treat epilepsy, then we're able to give them more invasive options. And that solely depends on whether they have focal epilepsy or generalized epilepsy. Not solely, but it is one of the criteria that kind of differentiates some of these potential choices that we're going to give them. So in general, this is the ILAE classification from 2017, which is the most recent classification that we have from them. We have focal onset seizures, we have generalized onset seizures, and then we have seizures where we're really unknown of where these seizures are coming from. With the focal onset seizures, we try to break it down to aware or impaired awareness, meaning could they answer questions? Could they remember things that you were saying to them? And then impaired awareness, meaning they're not remembering what you're telling them, and they have no real recollection of the seizure. And then we further break it down to the motor onset. So some of these things might be automatisms, like we talked previously, with lip smacking and repetitive movements in the hands. Clonic, meaning convulsive seizures. Tonic, meaning stiffening seizures. And myoclonic, meaning jerking seizures. There are, of course, a lot of types of motor types of seizures. And then non-motor onset seizures. And some of these could be just as simple as behavioral arrest or getting incredibly emotional, having dyscognitive kind of symptoms during your seizure. And these can all progress to bilateral tonic-clonic seizures. We also have generalized onset seizures that have their certain specific semiology. Many generalized onset seizures are generalized tonic-clonic seizures or generalized clonic seizures, which is generalized shaking, or generalized tonic seizures, which is generalized stiffening. Next, we're going to talk about the diagnostic testing after a first-time seizure or the diagnosis of epilepsy. So when you are thinking about diagnostic testing, one of the first things that we should get on all of our patients that have a first-time unprovoked seizure is an EEG. And so epileptic abnormalities are seen in 80 to 90% of patients with focal epilepsy. The first EEG that you get will uncover an epileptiform discharge or kind of like a spot of abnormal electrical activity up to 30 to 50%. That increases by the fourth EEG. So every subsequent EEG that you get, you could potentially gather more data, and this could increase up to 90%. However, around 10% of patients with epilepsy will not have interictal epileptiform discharges on their EEG. So this is to say that just because you do an EEG and you don't see anything abnormal, it doesn't necessarily mean that they didn't have a seizure. But then you'd have to rely more on their semiology or their seizure symptoms to really decide whether it sounded like an epileptic seizure, it sounded something less epileptic, like maybe a syncopal episode or something like that. The yield is substantially increased if you can get an EEG for these patients within 1 or 2 days after a seizure. So the best model would be that you see someone that had a seizure, maybe they come into the emergency department or they're following up the next day, and then that EEG is done within 1 to 2 days. That is really difficult for many, many institutions, including our institution, because the number of EEGs that would be warranted would be extremely, extremely high. So it's a really difficult task unless that patient is specifically coming into the ER, and then potentially it could be. It's the yield of an EEG is greater in patients with monthly seizures. So if you have more seizures more frequently, you're probably going to have more abnormalities. And of course, the longer the EEG is, the better detection rate it has. So a 20-minute EEG is going to have a lower yield than a 1-hour EEG. So a lot of times what we try to do with our first-time epileptic patients is we try to do 1-hour EEGs for their first initial EEG that we get. So this is just an example of a normal EEG. So essentially, really quick, the odd numbers are the left, the even numbers are represent the right hemisphere. This is the left temporal chain, as we call it, the right temporal chain, the left parasagittal chain, and the right parasagittal chain. And these are eye blinks that we see right here, are eye movements, and this is what we call a posterior dominant rhythm. So this is someone that I would say is nice and normal and awake. And then this next example is someone that is actually more in their sleep state. And I know that because these are sleep structures, but more importantly here is what you see, what we are calling an interictal epileptiform discharge. So just a very focal area of left temporal irritability or left temporal epileptiform discharge. Now, sometimes these things evolve. And so this is an example actually of an absence seizure. So this is, 3 Hertz spike and wave, which is what we traditionally see in a generalized seizure of absence etiology. And then this is actually an example of a left hemispheric seizure, or more precisely a left temporal seizure. So you can see this is kind of more of a normal background with that nice and normal rhythm, and then this is the abnormal part. So EEGs traditionally can show us many things. The one with the interictal epileptiform discharge, though, is what I would hope and plan to see on a normal routine EEG, typically to capture, an entire seizure in an hour-long study. The other part of this workup is an MRI brain and a CT brain. So MRI of the brain is the imaging of choice when you're trying to detect a focal epileptogenic lesion. It's just more sensitive in detecting those lesions, up to 15 to 20% of the time, more sensitive than CT brains. If you don't have an MRI of brain or just don't have access to it, then a CT brain is still helpful in identifying epileptogenic lesions and can certainly rule out some of the more serious pathologies, like maybe like an intraparenchymal hemorrhage or a very, very big tumor or something like that. But MRIs are going to be better for the more subtle kind of things that could potentially produce a seizure. So many factors that influence the yield of an MRI. MRIs in general have greater spatial resolution than a CT scan, but the factors that influence the yield of an MRI are the patient population. So what type of patients are generally being admitted in a certain area and what type of pathologies do they have. If many patients typically have like tuberous sclerosis, let's say, then the MRI is going to, of course, have a higher yield with that. What the pathological substrate is. So if it's very delineated focal cortical dysplasia, type 2B, maybe that's the type of focal cortical dysplasia that we'll see on an MRI. But if it's focal cortical dysplasia type 1, we might not see it on an MRI. So the pathological substrate makes a big difference. The quality of the scanner, of course, the imaging protocols, and then the experience of the interpreting physician. We're going to talk about these things a little bit more. So as I said, the patient population really matters. Those with intractable epilepsies, you probably are going to see more changes on an MRI than a first-time seizure. The quality of the scanner is really important. So when we use a higher strength magnet, we typically use 3T or 3 Teslas here. It's going to increase the structural yield. So in a study, 3T MRIs identified structural lesions up to 88% versus 74% in a 1.5T MRI. The imaging protocols that you use. So these are kind of, the first line is the minimum requirements that we would really like to use. But we would also like to have additional sequences like coronal sequences, coronal flare sequences, and additional T1 sequences that are in the coronal plane. And that helps us identify the mesial temporal structures. The expertise of the person that's reading it. So a non-expert radiologist might pick up these lesions, depending on what lesion it is, 39% of the time. If you have an experienced neuroradiologist, that would be more like 50% of the time they might pick something up on the standard MRI. And then if you have a dedicated neuroradiologist, then 85% of the time they're going to pick up these structural lesions. So even within the MRI, the person that's reading it could potentially have a different take on the Okay, the next thing that we're going to discuss is the use of anti-seizure medications and their efficacy. So there are many goals when we're picking an anti-seizure medication. Of course, like people to be seizure-free, that's a big goal of ours. We want to reduce their seizure severity. So maybe they're not having generalized tonic-clonic seizures anymore. Maybe we've reduced it down to their auras or their warning signs where they're not losing awareness. We want to avoid adverse side effects. So people are only going to take medications if they feel like they can tolerate it. So it's so important that we're asking our patients about compliance, and if they're not compliant, you know, maybe why they're not compliant. Maybe they're feeling so dizzy on a medication that they just won't take it. And then that's an indication to switch the medication. We want to suppress any subclinical epileptic activity. So some people have subclinical seizures. We want to make sure that these medications target those events as well. We want to reduce mortality and morbidity. So the more seizures that we can decrease, or the least seizure burden that someone can have, that's going to decrease their mortality and their morbidity. We want to address their comorbidities. Sometimes some anti-seizure medications can help two things potentially, or two pathologies. And so maybe that's the medication that we pick. We want to avoid drug interactions. So a lot of these anti-seizure medications can interact with many other medications. And so if you're on something that you absolutely need, let's say like warfarin for blood thinning, then you might not want to be on some of these enzyme-inducing anti-seizure medications. If you're on chemotherapeutic agents for your cancer, you might not want to be on some of the enzyme-inducer medications. They're going to interact and make that medication much less effective. And then we want prevention of epileptogenesis. So the general rule about medications or anti-seizure medications is that 50% of patients are going to gain seizure freedom on the first anti-seizure medication that you put them on and that potentially you maximize for them. An additional 20% of patients are going to gain total seizure freedom after 2 anti-seizure medications. So this is where we get the 70% of patients that are going to be seizure-free on 2 anti-seizure medications. Now, that does leave, you know, the rest of the population. So with the 3rd anti-seizure medication, less than 5% of patients will gain seizure freedom. And so that's, of course, a really, really dramatic decline. And so this 1/3 of the population, we say that these patients have intractable epilepsy. We're going to talk about that a little bit more, but this is kind of why we decide that we can try the 3rd anti-seizure medication, but also maybe, or definitely it's time to start more of a pre-surgical workup, meaning what else can we offer them aside from just anti-seizure medications? And so we've had, of course, a rapid influx of anti-seizure medications. Really, since the 1980s or so, we've had this whole 3rd generation drug line. It started just with bromide a long time ago. Then we added phenobarbital, and then we've just really had an influx of anti-seizure medications. Even with the last few years, we've actually had a lot of these additions of the last few anti-seizure medications. So we have about 44 anti-seizure medications in all. Some of them we don't use, obviously, we don't use a lot of these anti-seizure medications regularly, but they are available to us. I wanted to focus on the medications that you have more readily access to. And so this is why I picked these specific anti-seizure medications, just to give you the idea of mechanism of action and some pros and cons of them. But at the end, if you have any questions about any of the anti-seizure medications, please feel free to ask me. So Depakote is an anti-seizure medication that actually works on GABA-mediated channels. So that's its most kind of prominent mechanism of action, but it also has many different mechanisms of action. So it also works on the regulation of NMDA receptors. It inhibits T-type calcium channel opening, and then has prolongation of the sodium channel inactivation. So it does have several mechanisms of action, which can lead to lots of side effects, but sometimes can also mean that it's effective because of all these different mechanisms of actions. It's a medication that can be used for both focal and generalized epilepsy. So if you're not sure what type of epilepsy your patient has, this is potentially a medication that you could try, because it's not going to make the focal epilepsy worse or increase their seizure burden if they have focal epilepsy. So some pros to it is it's also used in the management of headaches. So if someone has severe migraines, Depakote can be used for epilepsy and also for the treatment of the migraines. It's a mood stabilizer. So if someone has anxiety or depression, this might be the medication that you reach for. And it can be loaded with IV dosing if needed. So if someone misses their medication dose, come to the emergency department, they've had several seizures, or maybe they're in status, that's an easy medication. That's their home medication that can be reloaded via IV formulation and give it back to them. It has a lot of side effects, as I mentioned. So the common symptoms that patients complain about are a tremor, so much so that it's like Parkinsonism type features, where you can have a significant tremor, but you also can have the gait instability that comes with it, the morning stiffness. So all of those kind of like Parkinsonism features. You can have significant weight loss, significant weight gain. It can also increase bone turnover. So it leads to things like osteopenia and osteoporosis. You can experience thrombocytopenia and liver injury. So platelets and liver enzymes need to be monitored every year. And if you do see a decrease or an increase of liver enzymes or a decrease of platelets, then you really want to think about switching the medication, or at least decreasing the dose and starting a second medication. Anyone that's on this because of the increased bone turnover needs a bone density exam after the use of it for 5 years. You don't want to do a bone density scan before the age of 30. That's when your bone density typically hits its adult age. So after that, you can start this. So if the 5 years happens at 26, you might want to wait until they turn 30 to do their first bone density scan. You want to monitor vitamin D levels. They should always be on vitamin D and calcium supplementation. It's an enzyme inhibitor, so it is going to interact with meds. And so you want to constantly be checking if they potentially are on a med that's going to interact with it. This is a medication that you do not want to use with women of childbearing age. If there's any potential that they have, that they could get pregnant, Depakote is is a medication that you would want to avoid in this population. The reason is because it has a really large increased risk of major congenital malformations, up to 25%, meaning 1 in 4 fetuses that are exposed to Depakote during pregnancy will go on to have major congenital malformations after they're born. Even if that child is in the 75% of the time, there's also things that could happen in their future, meaning that it could cause neurocognitive delay. And reports, it is showed to decrease neuropsych testing or IQ points down to less than 10. So meaning that it decreases their IQ points by 10. It also shows an increased risk of autism spectrum disorder. So even beyond the initial major congenital malformations, there are a lot of long-term effects that can happen when you're exposed to Depakote. So it's really important that we're trying not to start our patients on this medication if they have any, childbearing potential. The next medication is phenytoin. So this is a voltage-gated sodium channel blocker. It stabilizes the inactive state of the sodium channel, and then it prolongs the neuronal refractory period. And so this medication can be used for both focal and generalized epilepsy, but typically and traditionally we see it for focal epilepsy. The pro of it is you can load it with IV dosing, especially for status epilepticus. Sometimes that's really important. We need to do that. There are a lot of side effects with this one: dizziness, gait instability, double vision. These are the most common ones that patients complain of. But it really can cause other things like gingival hyperplasia, increased bone turnover, and thrombocytopenia. So these are things you want to monitor. Just like Depakote, you need to do the bone density scan and the vitamin D and calcium supplementation. They need to get regular dental exams. And And it's an enzyme inducer, so it's going to interact with a lot of meds. Specifically, it also interacts with birth control. So if you are trying not to get pregnant and you're on birth control and you're also taking phenytoin, it's going to metabolize that out of your system. And so there's very well a possibility that you could get pregnant. So that's important to really go over with your patients. This is a medication we really try to avoid in women of childbearing age as well, because it does have an increased risk higher than some of our safer medications of major congenital malformations. And there's intermediate risks of neuropsychological deficits. Phenobarbital is our next medication. It increases the duration of time that chloride channels are open and depresses the central nervous system. Can be used for both focal and generalized epilepsy. This again has an IV dosing. It does cause respiratory depression, so you want to be careful with your IV dosing of phenobarbital because it can cause respiratory depression and then can of course lead to intubation and things like that. Common symptoms include lethargy and tiredness. It can also increase bone turnover, cause liver injury, and thrombocytopenia. It's an enzyme inducer, so again, it has all the properties of interactions with medications and as well birth control. And it's a really hard medication to get off of once you place someone on it, because it's a barbiturate. Your body starts to get used to that medication. And so the weaning process of it can be really long and really slow. So typically we say you want to decrease by 20% of the total medication dose every 2 weeks. So it's a really long titration schedule off of it. And many people have withdrawal seizures while the titration schedule is being weaned off. And so it's just a very hard medication to get off of. Again, we don't want to use this medication with women of childbearing age because of the same things with Dilantin. It does increase the risk of major congenital malformations and has risks of neuropsychological deficits. Carbamazepine is a sodium channel medication, and it is a medication that we use specifically for focal epilepsy. So we do not want to pick this medication for a generalized epilepsy because sometimes it can make those seizures worse. Carbamazepine can be a mood stabilizer. So if your patient does have anxiety and depression, it could work as a mood stabilizer, although not as common, not as effective as other anti-seizure medications we have. And it can also be beneficial if your patient has trigeminal neuralgia. So if you have trigeminal neuralgia and an epilepsy, a focal epilepsy specific patient, then you could potentially try carbamazepine. It's very similar to the common side effects of the sodium channel blockers: dizziness, gait instability, double vision. It can cause hyponatremia, leukopenia, and increased bone turnover. So those are all things that we want to monitor. Again, since it's an enzyme inducer, it's going to have your interaction with your medication again and the birth control specifically. Gabapentin has an affinity for voltage-gated calcium channels, and it decreases excitatory neurotransmitters. It can be used for both focal and generalized epilepsy. It's beneficial if a patient has peripheral neuropathy. So if someone comes in with peripheral neuropathy and an epilepsy, you could potentially try gabapentin. It's not an inducer or an inhibitor, so it doesn't interact with any other medication, so that kind of makes it nice. Some cons to it is that, it can cause the tiredness, unsteadiness, and dizziness. If the patient has kidney disease, then you're going to have to change the gabapentin dosing. A lot of times also, which I didn't mention, is a 3 times a day medication. And so you just really have to think about if someone could take a medication 3 times a day. I'd probably forget the afternoon dose. I was on a 3 times a day medication, so that's the downfall of it. Levetiracetam is a medication that binds to SV2A receptors and inhibits presynaptic calcium channels. And so it can be used for focal and generalized epilepsy. It's not an inducer or inhibitor, so it's really good because it doesn't interact with any other medications. It's generally well tolerated, and it's one of 3 medications that we have enough pregnancy safety data on, and so we know that it's safe to use during pregnancy. The cons are that it has associated with agitation. About 20% of patients have agitation on this medication, and you do have to renally dose it, meaning if someone develops CKD or end-stage renal disease, then the dose does have to be decreased. Lamotrigine is another sodium channel blocker. Can be used for both focal and generalized epilepsy. This is a really great mood stabilizer. So if your patient is having anxiety and depression, this could be a medication that you could use for both anxiety, depression, and epilepsy. It's really well tolerated, and again, one of the 3 medications that are safe for pregnancy. Has all of the common symptoms that are associated with dizziness, double vision, and gait instability, those sodium channel blockers. There is a risk of Stevens-Johnson syndrome, so we have a really slow titration schedule. It takes about 6 to 8 weeks to get on a therapeutic dose of lamotrigine. It does interact with estrogen-containing oral contraception, meaning if you start to take an estrogen oral contraceptive, it will make Lamictal less effective. So something that we want to talk about or think about. And then a new black box warning came up on lamotrigine because in rat models, it was showing that lamotrigine could induce arrhythmia. So if someone has an underlying arrhythmia or general heart defect, sometimes we try to avoid using the lamotrigine. Oxcarbazepine is another sodium channel blocker. It's used for focal epilepsy. This is another medication that can make generalized epilepsy worse. It also is a mood stabilizer, well tolerated, and a safe pregnancy medication. Has similar common symptoms of those sodium channel medications. The main thing about this one is hyponatremia, so it can cause decreased sodium levels, and that's something extra you'd want to talk to your patient about. So the way we decide about anti-seizure medications is based on multiple factors. So the type of epilepsy, do they focus focal or generalized epilepsy, the side effect profile, patients' comorbidities. As I said, sometimes when they have something else, you might want to start a certain anti-seizure medication, their risks in pregnancies, the drug-to-drug interactions, and then the cost of the medication. Can they afford it? Okay, next we'll jump to intractable epilepsy and therapeutic models. So intractable epilepsy is when you fail 2 adequately dosed anti-seizure medications. So that adequately dosed means that they have to be at the maximum doses and you can't stop them early because of intolerability or medication non-compliance or something like this. This is the definition produced by the International League Against Epilepsy. They do not have to be at the same time. So you could have started one, maximized it, taken them off and started another one, maximized it, and they still continue to have seizures. That's intractable epilepsy. And the reasoning is because of the percentages that I gave you. At the time that you're starting a 3rd anti-seizure medication, there's a less than 5% chance that you're going to attain seizure freedom. And then the 4th medication trial is a less than 1% chance that you're truly going to attain seizure freedom. So it goes down pretty rapidly after your first 2 medication trials. So multiple therapeutic modalities is not a surgical talk, but just so you know, we could have surgical resection potentially. We now have laser ablation where we apply heat to the area and disrupt the neuronal signaling. We have vagus nerve stimulation, which is neuromodulatory therapy, which doesn't lead potentially to seizure freedom on the majority of cases, but can have a significant reduction of seizure burden. That's the same with deep brain stimulation. And now we even have responsive nerve stimulation. So many different modalities to try to treat epilepsy in different ways other than medications. Wanted to briefly talk about a seizure safety and rescue plan. I think when anyone has their first seizure, and in general, if they have epilepsy, they really need to know seizure first aid. So the main thing that we would tell patients is that you have someone with you, they would want to stay by you. They would want to make sure that you're safe. Anything around you should be moved out of their way. They should be turned on their side so that if they vomiting or anything like that, they wouldn't aspirate. And then the seizure should be timed. The seizure lasts more than 5 minutes, then an emergency vehicle should be called. If they're blue or the injuries, then they should also be called. And I find that many patients don't actually, know this. I don't think that it's common knowledge. So it's definitely something that we explain to every single patient. The other thing is we really tell people not to stick things in other people's mouth to prevent tongue biting, because that obviously could lead to choking. We try to give everyone a seizure rescue plan, meaning what do you do if you do have a seizure? There's a recent paper that came out that showed that 98% of people actually wanted a seizure rescue plan, even despite their seizure frequency. So some of these people are having less than one seizure a year, and they still wanted a seizure rescue plan. So we have many seizure rescue medications like benzodiazepines, intranasal medications, and rectal medications. I believe the medication most readily available for many people is Clonopin. So we would dose it like 1 tablet at the onset of an intense aura, or 1 tablet after a focal motor seizure or generalized tonic-clonic seizure. And the idea is that if they take 1 tablet after an intense aura, maybe that's going to prevent them from having a bigger seizure. Or if they take it after a focal motor seizure or a big grand mal seizure, maybe that would prevent them from seizure clustering. And so we want to make sure that we're not overprescribing. Generally, we say no more than 2 tablets of 1 milligram tablets of Klonopin in 24 hours, and no more than 10 tablets in a month, because you don't want to gain tolerance to it. This is an example of a sample seizure action plan. And then I know that I'm running overtime. So treating special populations, I think we really covered in the anti-seizure medications, but we want to consider women with epilepsy, the elderly, in terms of side effects and falls and monitoring bone health, and then those with underlying mood disorders. And then really quick, defining status epilepticus. I'm going to skip through this part, but essentially the diagnosis that the ILE put forth is status epilepticus is basically a condition in which you have an abnormally prolonged seizure, and after time point T1, once it gets to time point T2, that actually includes neuronal death and neuronal injury. So if we treat at point of T1, then we're hoping that we can avoid any of the long-term consequences that happen at point T2. And so to make this clear, you have generalized tonic-clonic status epilepticus. We want to treat at that 5-minute mark, because at 30 minutes is when that neuronal injury is happening. So we want to make sure we never get to this point, essentially. With focal status epilepticus with impaired consciousness, this was a little bit longer. So we have about 10 minutes that we really want to try to target, and if it lasts longer than 10 minutes, we're probably being more aggressive, so we don't get to the 60-minute. And then this is the Neurocritical Care Society and the American Epilepsy Society in terms of pathways of treatment of status epilepticus. They differ in the sense that Neurocritical Care Society is a little bit more aggressive in the ways that they administer. They administer an IV medication in this first 0 to 5 minutes, versus American Epilepsy Society is still stabilizing the patient and administers the first rescue medication. So that's kind of like a difference in the two societies. Eventually the same goal, and probably a difference about 5 minutes in general. Okay. Thank you so much. I'm sorry I went over a little bit. I just wanted to, bring to your attention that November is National Epilepsy Awareness Month. It's really important that we decrease the stigma and the discrimination against epilepsy patients. And so I always like to tell everyone that November is a time to celebrate our patients. International Women with Epilepsy Day is March 1st. So celebrating our women with epilepsy, empowering them. And then this has nothing to do with epilepsy, but these are my kiddos. Ari, who started his first day of kindergarten today, and then my little daughter, Maya, that's 15 months. I'll take any questions.
Beautiful children. Thank you for sharing that. Thank you, Dr. Matura. I think that was a really nice, comprehensive talk and organized very well. And I really also appreciated how you specifically focused on the anti-epileptic drugs that are used most frequently or available in Ethiopia. Dr. Michael was co-moderating, and I thought I saw them on the panelist list, but maybe he dropped off. Are there any questions for Dr. Maturu? I don't see anything in the Q&A or the chat, but please feel free to, we have a couple minutes here. Here's one question in the Q&A. Thank you for an excellent presentation. Can you talk about seizure dose of sodium valproate and carbamazepine versus pain dosing?
Okay, yes. So for carbamazepine, if we're talking about specifically pain related to trigeminal neuralgia or pain in general, usually the pain dosing can be slightly less aggressive than an epilepsy dose. So sometimes we are dosing them at maybe 100 milligrams specifically for carbamazepine twice a day, or 100 milligrams 3 times a day. An epilepsy dose can go much higher. So our doses are up to 1,200 milligrams daily. So, you know, a 600 milligram BID dosing would be sometimes what we need to target. Again, though, carbamazepine does have a lot of hyponatremia associated with it. So especially with your patients that are elderly, you really want to make sure that you're monitoring those sodium levels within the first few weeks and months, because if they get hyponatremia, then that's going to lead to another host of issues with more seizures. So it's kind of a balance there. Dilantin dosing, typically we start out with TID dosing. So if I would start someone out in the outpatient setting, I'd probably do 50 milligrams TID for 1 week and then increase it to 100 milligrams TID. If you have extended release version, that would be even better. Again, I think TID dosing is just very hard for any patient, but even more so our epilepsy patients, because they have a lot of cognitive impairment. So if you could switch to extended release, that would be awesome, if that's available. And then the other thing about Dilantin is just monitoring levels. It's very easy to get toxic because certain things can really increase the dosing of it and make it very toxic. And then certain medications randomly can really decrease phenytoin and make it not effective at all. So it's just something that you really want to monitor.
Okay. Couple more questions. How do we differentiate hysteric presentations of patients with seizures, especially in the emergency department?
I'm not positive what the hysteric presentation means. If you can elaborate, maybe you can help.
I wonder if it's, I don't know if the person wants to elaborate more in the chat, but maybe they just mean the diagnosis of seizures in the emergency department.
Okay. So in general, hysteric meaning maybe potentially like emotional responses that occur prior to seizures, like having increased anxiety or increased emotions prior to a seizure. It can be really hard to differentiate when you're first trying to figure out a patient's semiology, if it's truly epileptic or not. I would say in general, though, with an aura or a warning sign to a seizure, these things are going to last seconds to minutes. If they're lasting hours, it's unlikely an aura. So that's something you want to think about when someone's presenting to you. And typically auras are really, really overwhelming. So they might even cause more symptoms if you're able to probe the patient a little bit more. Like, are they causing episodic confusion? Do they feel really nauseous and want to vomit after? Do they need to sleep for many hours after? So these are signs that make that symptom a little bit more extreme and could potentially make you think a little bit more down that seizure pathway.
And I see Dr. Michael is actually back as well. Dr. Michael, I don't know if you want to comment on anything from Ethiopia perspective, and could also mention some of these other questions in the chat.
Can you hear me? Can you hear me? Hello?
Yes, we can. Yes, we can hear you, Dr. Michael. Yep.
I'm really sorry about. I was not following the seminar since I was in the bank having some process around. It's my apology to join late. Sorry for not giving comments on your request. Sorry.
Oh, no worries at all. I think there are just
That's fine.
2 more questions. Maybe
Yeah.
I'll just so one is, can we use phenytoin or phenobarbital during pregnancies because the other medications are not available? Great question. Yeah, so we can only do what we can do. we want to keep everyone seizure free. That's our main goal. If patients are having generalized tonic-clonic seizures during pregnancy, it's not good for mom, of course, and it's not good for baby. It can lead to preterm labor, miscarriages, all kinds of things. And it can lead to patient death. So that's our first and foremost goal. And so if I had to choose, I would probably choose, well, it kind of depends. They both have increased major congenital malformations. Phenobarbital does have a higher poorer neuropsychological outcome after. So if you have to pick maybe phenytoin over phenobarbital, that's going to have its own limitations though, because sometimes, phenytoin won't work for your patient. You have to use phenobarbital. At the end of the day, you're just using what you can use. So if those are the only medications that you have to choose from, then you just pick the best one for your patient. And just give them the information, right? All we can do is educate our patients. And once they have that information, then we empower them with them, and then they're going to make the best decision for themselves. Status epilepticus in an area that has no IV preparation. Such a great question. So you can actually orally load a patient with any medication. It does not have to be an IV preparation. So you could, if you can drop an NG tube down, then you can orally load them even with things like carbamazepine and Oxcar. You're just going to give a bigger dose. And if they're in status epilepticus, they're obviously have altered mental status. You're probably protecting their airway in other ways. So you can orally load a medication through the NG tube. It's not going to be as effective, and the time to treat is going to be less than an IV medication, but it's definitely going to be more effective than obviously not doing anything. So I would just orally load with a high dose of like your oxcarbazepine, your carbamazepine. Any medication can be orally loaded, honestly.
Thank you, Dr.
Let me know if I'm
McDougall.
out of time.
I think in the interest of time,
Yeah,
I was going to say, I think we have to move on, but there might be one other question. If you have time, maybe you can answer in the chat, but otherwise, thank you so much for a wonderful presentation.
Thank you so much for having me. It was, if I put my email in the presentation, so if you guys have any other questions, I'd be happy to answer over email. Thank you.
Thank you. Okay, and then moving on to our last talk of the day. Dr. Esaki, are you available to share?
Yes. Okay.
Okay, we see your video on, and just testing here.
Let's see. Are you able to see the screen?
Yep, we see your slide. It's in the it's in the in the editing version of the PowerPoint app.
Is this good now?
Yep, now it's good. Perfect. Okay. So I do want to mention we have a co-moderator from Ethiopia, and I apologize, I might be pronouncing your name wrong, Dr. Nigus Debre, who is an assistant professor of hematology from Addis Ababa University. So thank you for helping to co-moderate.
Thank you so much, Dr.
And I will, thank you. So yeah, Dr. Rajalakshmi Esaki, thank you for being here today. She is a clinical assistant professor of internal medicine in our division of hospital medicine and focuses a lot in the care of our cancer medicine patients in our James Cancer Hospital. So she will be talking to us today about venous thromboembolism in cancer patients. Thank you so much, Dr. Esaki.
Thank you, Dr. Clark. Thanks for the introduction. Hello, everyone. I'm Rajalakshmi Saki. I'm an assistant professor of internal medicine in the division of hospital medicine. I've been practicing as an oncology hospitalist, and venous thromboembolism is one of the most common presentations we see in cancer medicine patients. And I'm excited to share the details of it today. So thromboembolism in cancer, it's also called as CAT, cancer-associated thrombosis, and VTE is the venous thromboembolism. It encompasses DVT and PE. Patients with malignancy are often experience increased risk of thrombosis, both venous and arterial. The thromboembolic disease can be the first manifestation of occult malignancy or more commonly occur within 6 months of a cancer diagnosis. Thrombotic events are the leading cause of mortality after cancer itself, despite being a largely preventable disease. Today, I'm going to discuss in this topic about the incidence and risk factors, etiology, epidemiology, and pathophysiology of this thromboembolism. And we will also see some clinical presentation, signs and symptoms, and diagnosis. And also, I would like to discuss some complications. And then finally, the major part is the treatment. What are the indications? What are the contraindications, prevention, and the treatment about anticoagulation. And also, I want to touch base with the future emerging treatment options available in for future, and some conclusion with take-home points. All right, let's start with incidence and risk factors. The risk of venous thromboembolism in people with cancer has increased threefold over the last 2 decades and is 9-fold higher than in the general population. The mortality rate of people with VTE in cancer is 2 to 3-fold higher compared with those without venous thromboembolism. Not only are patients with cancer at higher risk for venous thromboembolism, but venous thromboembolism is a risk factor for poor outcomes among patients with cancer. The thromboembolism, including venous and arterial events, as I mentioned before, is the second leading cause of death among patients with cancer. The risk of VTE recurrence is also high, even with administration of anticoagulation therapy in cancer patients. Now let's discuss about the risk factors. Clinical and biological factors that increase the risk of thromboembolism in patients with cancer includes the site of cancer, advanced stage, that is metastatic stage, use of central venous catheters, treatments such as anti-angiogenesis, chemotherapy, immunotherapy, surgery, and hospitalization are all some of the factors influence the risk of thromboembolism. Studies have shown the highest risk of VTE in patients with pancreatic and brain cancers, although the risk is considered quite high in patients with gastric, esophageal, ovarian, and hematological malignancy, particularly multiple myeloma and non-Hodgkin's lymphoma. People with cancer undergo surgical resection are at significantly higher risk of getting a VTE in the pre- and post-operative period. Other risk factors include ethnicity. Hispanic and Asian patients with cancer have a lower incidence of VTE complications compared with Caucasian or African American patients. History and family history of VTE is another risk factor. Other than that, comorbidities like renal failure, respiratory disease, acute infection, and obesity, venous stasis like prolonged immobility in a critically ill cancer patients are all other risk factors. Concomitant prothrombotic genetic risk factors such as factor V Leiden and non-O blood types are associated with VTE events. Chemotherapy also increases the risk of cancer-associated thrombosis. For example, different agents including cyclophosphamide, cisplatin, doxorubicin, 5-fluorouracil, lenalidomide have been found to increase the risk of VTE significantly. So now coming to the etiology, multiple factors contribute to the increased risk of arterial and venous thromboembolism in cancer patients. To number them, tumors, tissue, and anatomical factors, patients' comorbidities, including obesity and advanced age, surgical and medical oncology treatment. Now coming to the epidemiology, the incidence of venous thromboembolism in patients with cancer is substantially higher than in general population. Clinically evident venous thromboembolism has been noted in 2 to 15% of patients with cancer, and the incidence could be higher if considering subclinical disease. Trauzeau observed as early as in 1865 an association between malignancy and venous thrombosis. Over a century, subsequent inquiry has confirmed his initial finding. The annual incidence of venous thromboembolism in general population is roughly 100 cases per 100,000 people, which is 0.1%, with roughly 1/3 meeting criteria for PE. The incidence of, there are a few case control studies I want to quickly touch base. There is one case control study in Netherlands, examined 3,220 patients aged 18 to 70, found overall risk of venous thrombosis to be 7-fold higher, highest risk in the first few months after diagnosis, highest risk in patients with hematological malignancies, lung cancer, GI cancer, or with distant metastasis. Another case control study done in Minnesota here in USA found a 4-fold increased risk of VTE in patients with cancer while receiving chemotherapy. Observational cohort study published in 2017 has estimated the incidence of first 10 recurrent VTE among patients with active cancer to be 5.8 and 9.6 per 100% years, respectively. Now, coming to the main part of pathophysiology. Before going to the details of the pathogenesis of cancer-associated thrombosis, let's talk about this newer terms. Next, new alphabets of atherothrombosis, which is neutrophil extracellular traps, CHIP, clonal hematopoiesis of indeterminate potential. So how NETs contribute to the thrombosis? They promote thrombin generation, entrap platelets and fibrin, form a solid state reactor with tissue factor, activate endothelial cell tissue factor production and procoagulability. Now coming to CHIP, which are acquired mutations with age. Clonal hematopoiesis increases with age. Those with clonal hematopoiesis have much greater risk of cardiovascular events than of developing hematologic malignancy. Increased RDW in peripheral blood seen in patients with CHIP. There are a lot of information in lab research and in trials. Hopefully we'll get more details in the upcoming years. As I mentioned before, patients with cancer often have a hypercoagulable state due to the production of substances with procoagulant activity, just like tissue factor and cancer procoagulant. High thrombotic potential cancers are pancreatic and ovarian. Obesity, which has 2 to 2.3% risk of a VTE, and age more than 60 years are all, as we discussed already, they are the highest risk factors. This is a quick review of Virchow's triad that happens. Hypercoagulability, venous stasis, and endothelial damage lead to the thrombosis. Now, coming to the pathogenesis of cancer-associated thrombosis. So it seems to be different compared with the development of VTE in patients without cancer. The underlying mechanisms of cancer-associated thrombosis is activation of the coagulation, dysregulation of fibrinolytic systems, inflammation, and cytokine production. Tissue factor produced by malignant cells appear to trigger the coagulation cascade, leading to the formation of factor 10A, while some cancer cells can produce cancer procoagulant that acts directly on the factor 10A. In addition to the potential procoagulant effect of cancer cells, anti-cancer therapy has shown to be an additional cause of cancer-associated thrombosis. So now coming to the clinical part, history and physical are more important. Patients can present with venous thromboembolism as DVT or PE, and less likely as arterial thromboembolism with ischemic stroke and myocardial infarction. Now let's touch base a little bit about the clinical presentation of DVT and PE. Deep venous thrombosis in patients with cancer mostly affects the veins in the lower limbs and usually presents as painful swelling and redness of the affected limb. Physical examination findings may include unilateral erythema, warmth, tenderness, difference in cough or thigh circumference, dilated superficial veins, and localized pain along the course of the involved vein. Rarely, patients can develop DVT in the internal jugular vein that can present as neck pain, swelling, erythema, headache, blurred vision, dizziness, and even altered sensorium. Other unusual sites of VTE include splanchnic, mesenteric, and portal veins that can present as abdominal pain, ascites or GI bleeding. However, these are mostly found incidental on staging or restaging scans for malignancy. VTE in cerebral veins may present as focal neurological deficits or seizures too, but those are not very commonly seen as the DVT and the PE. The use of central venous catheters predisposes patients to upper extremity DVT that presents with features similar to those of the lower limb DVTs. I just wanted to touch base about a little bit about the Homan sign. It's, as we all know, it's a quickly and forcefully dorsiflexing the patient's foot at the ankle while the knee is extended and then squeezing the patient's calf with the other hand. A positive Homan sign is patients having pain in the calf or behind the knee. This Homan sign should not be used as a confirmatory test or rule out DVT. Now, the signs and symptoms of pulmonary embolism. It's another form of VTE presentation in cancer patients and can be a cause of sudden death. So the common symptoms include shortness of breath, chest pain that is worse on inspiration, which is a pleuritic type presentation, non-productive cough, orthopnea, cough pain or swelling, and hemoptysis. Sometimes they present as isolated syncopal episode too. So all syncopal episodes should have the workup should include ruling out PE. On examination, patient may present with tachycardia, tachypnea, loud S2, jugular venous distension, and in the EKG, you can also see a S1Q3T3 pattern, which is a large S wave in the lead 1, Q wave and inverted T wave in the lead 3. This pattern indicates right ventricular strain, and it is very rarely found in the EKG. Then sometimes patients present with massive PE, which is associated with cardiovascular shock or persistent hypotension. Submassive PE is associated with right ventricular dysfunction on echo or CT angiogram of the chest. They can also present with elevated troponin, beta and P. Now, the next is the diagnosis. So generally, the following are used for diagnosis, and we'll talk in detail about each of them. D-dimer, which is age-adjusted D-dimer. The cutoff levels is age into 10. Wells criteria, we use DVT score more than 1, PE score more than 4, duplex ultrasonography of the lower extremities, CT, pulmonary angiography of the chest, VQ scan. Let's talk a little more detail. An elevated D-dimer is very nonspecific, especially in patients with cancer. It can be elevated without thrombosis too. However, one thing is like if it is negative, we can rule out. But in cancer patients, if the clinical suspicion is high, we can directly order the imaging studies to confirm it. The pretest probability based on the Wells criteria, our Geneva score, is used to guide evaluation for pulmonary embolism. Despite low or intermediate risk based on pretest probability, Proceeding with imaging is appropriate if clinical suspicion of VTE is high, as it is common in patients with malignancy. If the patient is at high risk based on pretest probability, can proceed with imaging and there is no need to check D-dimer. Compression ultrasonography or bilateral lower extremity venous duplex ultrasound is the mainstay for diagnosing DVT in the lower extremities and the upper extremities. Computer tomography, that is the CT pulmonary angiography of the chest, is the mainstay for diagnosing pulmonary embolism. Although VQ scan, which is the ventilation perfusion scan, is preferred to limit radiation exposure and for patients with contrast allergy or renal failure. Malignancy is the most likely cause of unprovoked thromboembolic disease. In a recently published retrospective study of 245 patients with venous thromboembolism, 4.1% had an occult malignancy. However, during the evaluation of unprovoked thromboembolic disease, the workup should include the following other diseases has to be ruled out. Ruling out of thrombophilic disorders, nephrotic syndrome, antiphospholipid syndrome, myeloproliferative neoplasms, severe liver disease, inflammatory bowel disease. These are the differentials. Now let's talk about the complications. So serious complications of thromboembolic event in cancer patients are increased risk of recurrent thrombosis, increased risk of bleeding during anticoagulation therapy, increased hospitalization rates, and increased mortality. Recurrent VTE after cancer treatment should prompt evaluation for cancer recurrence or a new primary malignancy. The non-fatal complications of venous thromboembolism are chronic thromboembolic pulmonary hypertension, which is CTE-PH, post-thrombotic syndrome, which is from venous insufficiency, presents as venous ectasia, skin induration and edema, hyperpigmentation, venous ulcers. The third one is post-PE syndrome with functional and exercise limitations. It was mostly studied in the ELOPE study. Now, coming to the treatment indications. The indications and contraindications to treatment of acute venous thromboembolism in cancer patients are the same as patients without cancer. All incidental VTE should be treated. The American Society of Hematology recommends short-term anticoagulation for 3 to 6 months for incidental PE in patients with cancer compared with observation alone. However, isolated subsegmental PE can be observed on a case-by-case basis without anticoagulation therapy in the absence of ultrasonography-detected lower limb DVT. It's our practice to screen for lower extremity DVT in the presence of isolated subsegmental PE before deciding about anticoagulation. The decision to start anticoagulation for incidental visceral vein thrombosis must be based on diagnostic certainty, chronicity, extent of thrombus, bleeding risk, and patient preference. The untreated PE is associated with 30% mortality. Untreated DVT is associated with 50% PE. Occult cancer screening, risk of cancer within 12 months of VTE diagnosis is 5.2%. The contraindications to anticoagulation. Any active bleeding. Malignancy has higher incidence of major bleeding, 6.5 to 18%. So the risk of bleeding includes older age, people more than 60 or 65, higher intensity of anticoagulation, prior history of GI bleed, metastatic cancers, recent bleeding, including any intracerebral bleed or a recent stroke, creatinine clearance less than 30 ml per minute, and any recent surgery, pre-existing bleeding diathesis, platelet count less than 50,000, and coagulopathy are all high risk of bleeding, and anticoagulation should be seriously considered before completely concluding. A quick review of coagulation cascade. As we all know, coagulation cascade includes intrinsic, extrinsic pathway, and the common pathway. In the common pathway, factor 10A acts, and then 7A, 2 and 1. The extrinsic pathway is started by factor 7, and intrinsic pathway factor 12, 11, which again activates 9 and 8. Now, the main treatment part with the anticoagulation therapy. So the available anticoagulation treatment for VTE in cancer patients are unfractioned heparin, low molecular weight heparin, includes enoxaparin, dalteparin, tinzaparin, nadroparin, and bemiparin, vitamin K antagonist, warfarin, fondaparinux, and the DOACs, direct oral anticoagulants, apixaban, rivaroxaban, edoxaban, and also dabigatran, which is a direct thrombin inhibitor. Let's talk about one by one. Unfractioned heparin is used both for prophylaxis as well as for therapeutic treatment of VTE. The prophylactic dose is usually given as 5,000 units Q8 hours, and the therapeutic dose is given as a drip. Low molecular weight heparin. It remains the preferred and monotherapy in the standard treatment for cancer-associated thrombosis. The first large study to address the benefit of low molecular weight heparin in patients with cancer was CLOT trial, randomized comparison of low molecular weight heparin versus oral anticoagulant therapy for prevention of recurrent VTE in patients with cancer. The CLOT randomized 672 patients with active cancer and acute symptomatic VTE to receive dalteparin. They gave 200 international units per kilogram subQ for 5 to 7 days, followed by Coumadin with the target INR of 2.5. And the other group received dalteparin, 200 international units per kilogram once daily for the first month, and then continued 150 international units per kilogram for a total of 6 months. So the analysis showed lower rates of recurrent VTE compared with 15.8% in the vitamin K antagonist group. No significant difference in major bleeding or any bleeding reported between the groups. Another large global randomized controlled trial, CATCH, the comparison of acute treatments in cancer hemostasis. It compared outcomes with warfarin and the low molecular weight heparin and showed no statistical difference in rates of recurrent VTE or major bleeding. The usual dosage recommendation for low molecular weight heparin is 1 milligram per kilogram every 12 hours and 1 milligram per kilogram once daily for patients with a creatinine clearance less than 30 ml per minute. The currently available are enoxaparin, which is used more among the low molecular weight heparin. The other low molecular weight heparin are dalteparin, nadroparin, tinzaparin, and bemiparin. Now, the vitamin K antagonists, which are traditionally used before all these newer drugs were available, they inhibit the synthesis of vitamin K-dependent clotting factors 2, 7, 9, and 10. Traditionally, vitamin K antagonist warfarin have been the mainstay of treatment in the VTE. Because of the need for regular laboratory monitoring, the therapeutic range maintenance, dietary restrictions, and drug-drug interactions with commonly used chemotherapy agents and less predictable pharmacology, the current practice has shifted toward the use of low molecular weight heparin and DOACs. Then the next one is the fondaparinux, which is a synthetic 10A inhibitor. We'll discuss more about this individually, their action and everything. Used subcutaneous route for anticoagulation and used as an alternative anticoagulation for patients with acute heparin-induced thrombocytopenia with thromboembolic complications. It is also used for VTE prophylaxis during the post-op period after orthopedic surgeries. Coming to the DOACs, direct oral anticoagulants, which include oral direct thrombin inhibitors and factor Xa inhibitors. The direct thrombin inhibitors prevent thrombin from breaking into fibrinogen to fibrin. They bind to thrombin directly rather than by enhancing the activity of antithrombin, as is done by the heparin. Parenteral direct thrombin inhibitors are bivalirudin, argatroban, and desridin. The only oral direct thrombin inhibitor available for clinical use is dabigatran. And dabigatran is a better choice in liver failure patients because it's 80% metabolized in the kidney. The next is the Xa inhibitors. Direct Xa inhibitors prevent factor Xa from breaking into prothrombin to thrombin. They bind directly to factor Xa rather than enhancing the activity of antithrombin 3, as is done by the heparin. Xa inhibitors are apixaban. This is a better choice in renal failure patients. Rivaroxaban, edoxaban have been studied in the treatment of VTE in patients with cancer. But there have been no cancer-specific data published for dabigatran for this indication. Oral route, fixed dosage, no requirement for routine monitoring or dietary restrictions as with vitamin K antagonists have increased the use of DOACs for long-term management of VTE in cancer patients. However, DOACs have some significant drug-drug interactions too, particularly inducers and inhibitors of cytochrome P450, and also P-glycoprotein immunomodulating agents such as tacrolimus and cyclosporin. Also, caution is needed when DOACs are used for the treatment and conditions with hepatic renal impairment, thrombocytopenia when used with antiplatelet therapy. Several randomized controlled trials have shown non-inferiority of DOACs comparing to low molecular weight heparin. The Hakuzai VTE cancer trial proved non-inferiority of the oral factor Xa inhibitor edoxaban over dalteparin. In the Caravaggio trial, it was found apixaban to be non-inferior to low molecular weight heparin in the treatment of cancer associated with VTE without an increased risk of significant bleeding. In general, guidelines from various societies, including ASCO, American Society of Clinical Oncology, ASH, American Society of Hematology, International Initiative on Thrombosis and Cancer, NCCN National Comprehensive Cancer Network, which are some of the general guidelines from these societies regarding treatment of acute VTE in patients with active cancer, show a substantial consensus. Both DOACs and low molecular weight heparin are considered preferred treatment options. In the absence of risk factors such as renal failure, hepatic impairment, thrombocytopenia, drug-drug interactions, upper GI malignancy with an intact primary tumor, direct oral anticoagulants are the preferred agents, whereas low molecular weight heparin are preferred for those with these risk factors. Anticoagulation should be tailored based on patient characteristics and preferences, and also other range of factors, including risk factors like risk of bleeding, medical comorbidities, financial cost, risk of clot. These all has to be considered. Individualized treatment regimens should be decided after a shared decision-making with patients. Anticoagulation should be reassessed on a regular basis as patients' cancer status and management change over time. The current guidelines from all these societies we discussed earlier recommend that anticoagulants must be used with a minimum of 6 months, continued beyond at the same dose if the patient has active cancer or metastasis or is undergoing continued chemotherapy, provided there is no increased risk of bleeding. It's appropriate to use vitamin K antagonist in patients for whom access to DOACs or low molecular weight heparin may be limited, such as in low resource settings or for prohibitive copay costs. Now, the treatment phases. So, as we discussed earlier in detail about the anticoagulation options, first we divide into acute phase, which is the first 5 to 10 days, then the long-term phase, which is the 3 to 6 months, and then the extended phase more than six months. So acute phase usually low molecular weight heparin, unfractioned heparin, fondaparinux, apixaban, rivaroxaban are the most common ones used. They both fall under low molecular weight heparin and direct oral anticoagulants. For the long-term continuation, we can continue the low molecular weight heparin, apixaban, edoxaban, and rivaroxaban. For extended phase, that is more than 6 months use, low molecular weight heparin, apixaban, edoxaban, and rivaroxaban, or even vitamin K antagonists can be used. Extended anticoagulation beyond the initial 6 months should be considered for patients with active cancer in whom the risk of recurrent thrombosis is higher and also outweighs the bleeding risk. Again, to remind, anticoagulation should be tailored based on patient characteristics and preferences, and also the other factors, including risk of bleeding, medical comorbidities, financial cost, and risk of clot. Individualized treatment regimen should be decided after a shared decision-making with the patients. Anticoagulation should be reassessed on a regular basis as patients' cancer status and management change over time. Now, coming to the prevention of VTE, we can, there are two options, pharmacological prophylaxis and mechanical prophylaxis. Pharmacological thromboprophylaxis used in the hospitalized cancer patients as well as surgical patients in pre-post-op based on the risk assessment. Current guidelines from the NCCN recommend anticoagulation with unfractioned heparin or low molecular weight heparin in hospitalized cancer patients as thromboprophylaxis. Fondaparinux is used for VTE prophylaxis after orthopedic surgeries mostly, and also used as an alternative anticoagulation for heparin-induced thrombocytopenia. The mechanical prophylaxis should be used instead of anticoagulation in patients experiencing active bleeding, thrombocytopenia, that's platelet count less than 50,000, evidence of hemorrhagic coagulopathy, or have an indwelling neuroaxial catheter. Contraindications to the use of mechanical prophylaxis include acute DVT and severe arterial insufficiency. Regarding the outpatient VTE prophylaxis, surgical pelvic or abdominal oncology patients would benefit from continuing VTE prophylaxis up to 4 weeks post-op. Vena cava filters. So, when do we use this vena cava filters in patients with VTE? When there is an absolute contraindication to anticoagulation therapy. Retrievable inferior vena cava filters may be indicated in the acute phase of venous thromboembolism in cancer patients when there is an absolute contraindication to anticoagulation treatment, or as an adjunct to anticoagulation in patients with recurrent VTE or extension of thrombosis despite optimal anticoagulant therapy. Now, I want to touch about the future options, emerging treatments. Factor XI inhibitors. So monoclonal antibodies are being investigated as potential additional agents for the prevention of thromboembolism. Abelacimab, a monoclonal antibody that inhibits factor XI activation and activity, is currently being studied in 2 randomized trials. The 2 ongoing phase 3 multicenter randomized controlled trials are ASTER and Magnolia trials. They are evaluating the efficacy and safety of abelacimab in the management of cancer-associated thrombosis. The second one is the tissue pathway factor inhibitors, such as recombinant anticoagulant protein 2C. It's derived from hookworms, have also showed promise in preventing DVT from acting directly on the coagulation cascade. The third one, aptamers, which are short segments of single-stranded DNA or RNA, and are being studied specifically to inhibit propagation. I want to touch base a little bit about the reversal of anticoagulation. I think I have time. So as we already seen about the anticoagulants, both oral and parenteral options, let's see what are the oral anticoagulant reversal options we have. So first, the vitamin K antagonist, which is the warfarin. The preferred options are, first, you can give vitamin K, either IV or PO for all patients to reverse the anticoagulation effect. And the second one is the 4-factor PCC. It's an unactivated prothrombin complex concentrate. The alternative agents option is like FFP. Then to reverse the anti-10A inhibitors, the preferred agent is andaxidant alpha. Alternate agent is 4-factor PCC. It's used weight-based dose or a fixed dose. For dabigatran, the preferred agent is edrasuzumab. The alternative agents are RF7A, or even patient can go for dialysis too. For the parenteral agents, as we know, for unfractioned heparin and low molecular weight heparin, you can try protamine sulfate. For argitrobin and bivalirudin, they have short life, so reversal agent is not recommended at this time. So from all these discussions today, I want to summarize the take-home points. So venous thromboembolism is one of the leading causes of morbidity and mortality for cancer patients. Patients with cancer have a hypercoagulable state due to the production of substances like procoagulant activity, example, tissue factor and cancer procoagulant. High thrombotic potential cancers are pancreatic and ovarian. The thromboembolic events can either occur in patients with a known history of malignancy, or it can present as the first isolated manifestation. The diagnosis of VTE, including DVT, is by compression ultrasonography, and for the PE, CT pulmonary angiographic study. And when you are working up the presentation to rule out a VTE, we should also rule out other differentials, including thrombophilic disorders, nephrotic syndrome, antiphospholipid syndrome, myeloproliferative neoplasms, severe liver disease, and inflammatory bowel disease. And we talked about the contraindications to anticoagulation, like active bleeding. The other risk factors for bleeding is older age, more than 65, high intensity anticoagulation, prior GI bleed, metastatic cancers, recent bleeding, recent surgery, creatinine clearance less than 30, pre-existing bleeding diastasis, platelet count less than 50. Both direct oral acting anticoagulants and low molecular weight heparin are considered preferred treatment options. Anticoagulants must be used for a minimum of 6 months and continued beyond at the same dose if the patient has active cancer or metastasis, or is undergoing continued chemotherapy, provided there is no increased risk of bleeding. And always the anticoagulation should be, the decision has to be as a informed decision with the patient, and has to be revisited if they are continued more than 6 months. IVC filters can be used in patients with absolute contraindication for anticoagulation. And that's all today I have to share. Thank you, and I can take any questions.
Thank you so much, Dr. Isaki. I thought that was a very nice overview, and thank you for summarizing your points in that last slide there. I would like to invite, where is Dr. Niguse? Are you there? Perhaps you can share some, any comments, especially compared to your practice there in Ethiopia, and then maybe we can field some of that. Looks like there's some questions in the Q&A.
So thank you very much, Dr. Saki. It was a very nice, organized, and comprehensive presentation of this important topic. So most of the things were included and touched, so I don't have much to add. So we would entertain if there are any questions from the attendees, from the participants. So I think we have 2 questions in the chat box, in the QA section. So I'm not sure if you are visible to you, Dr. Isaki.
Yeah, the first question I'm reading is, what would be the preferred anticoagulation of choice in cancer patients, DOAC versus low molecular weight heparin? There are some trials showing better efficacy in DOACs. As all these trials, finally at the conclusion, they all studied the easy access as well as the availability. And also, mainly, they all studied about the bleeding risk. So at this point, the guidelines says like they both are equally effective, and that's why we have this informed decision about DOACs as a higher cost as well as but easy access. So, and the convenience for the patient. So in our current practice, we if the patient comes with a higher risk or any other comorbidities, we try to use the low molecular weight heparin, but when they are ready for discharge, we send them with direct oral anticoagulants. And some patients, most of the times, they were started directly on the direct oral anticoagulants. We give the loading dose followed by the regular dose, continuation of dose. And so either one is fine, but I see in practice more and more direct oral anticoagulants are used. And
thank you very much. So just to add from our perspective, so this in our setup, molecular weight heparin is not widely available in most of the public hospitals, but is available in most of the private centers in Addis Ababa. From the DOACs, we have rivaroxaban and apixaban, which are again available in the private settings, but these drugs are not widely available in the government or in the public hospitals widely. So the choice depends on the specific patient condition, like with regard to the specific malignancy, the comorbidities and bleeding risk, and so on. So the choice of specific agents should be individualized, but generally, as you well said, so the efficacy is more or less comparable for most of the cancer-associated thrombosis. And for patients with, especially with significantly impaired renal function, so both of the agents are more or less contraindicated. So warfarin is still an option in this group of patients. And from cost perspective, so in our setup, the cost of rivaroxaban and enoxaparin are more or less comparable. So you can choose any of them. And warfarin is still an option in our setup because it is widely available in most of the centers. It is cheaper, but the risk of bleeding associated with warfarin is significantly higher in patients with cancer. So it requires frequent monitoring. So this is what I want to add. So I think we have another question as well.
Yeah, I see. Can we discontinue warfarin in a patient with cancer-associated DVT who was on unfractioned heparin with INR of 2.5 in less than 5 days overlap? Yes, you can. If you're planning to send the patient home on, oh, you asked, can we discontinue warfarin? So you have to maintain, if the patient, I'm sorry, I don't know if I have understood the question. So if you're planning to maintain the warfarin as a long-term anticoagulation for that patient, You should have the INR maintained 2 to 3. And I don't understand who was, why would you discontinue the warfarin? Is that because of some bleeding risk? I didn't understand. What was the exact question?
I think I think it is to mean, can we discontinue heparin? Once the
Oh,
INR
I think
becomes
so.
2.5 within less than 5 days of overlap.
Yes, you
Should
can
we-
discontinue the heparin. I think probably that's why it says discontinue warfarin. Yeah. Correct. If you have overlap for 5 days, yes, by the time the coagulation cascade is activated, so you can discontinue the heparin and send patient home on warfarin. Use of anticoagulations versus risk of tumor bleeding in general. It is higher, as we discussed, the incidence is higher with pancreatic and ovarian cancers too. And in fact, any brain solid tumors has an increased risk of bleeding. So you have to always weigh the risk benefits, and especially in the situations when they have like renal failure with creatinine clearance less than 30. And also if they have recent surgeries and prior history of GI bleed, thrombocytopenia, these all put the patient under risk. So you have to always like weigh the risk benefits, and based on that, you have to decide. I think that's all.
Thank you very much.
Thank you.
I think if there are no further questions, thank you very much, Dr. Saki, Dr. Clark, and all the attendees for your active participation. So it was a very nice presentation, and it was a very nice session. Thank you very much.
Thank you. Thanks for having me.
Thank you. Thank you, everyone.